Okay, hi everyone. Thank you for attending today's webinar, Sleep and MS, Perspectives from a Neurologist and a Sleep Physician.
Hi everyone, welcome. In the spirit of reconciliation, MS Plus acknowledges the traditional custodians of the country throughout Australia and their connection to land, sea and community. We pay our respects to the elders past, present and extend that respect to all Aboriginal and Torres Strait Islanders peoples who are joining us today. Thank you everyone for joining us. Without any further ado, I will set in motion the webinar for you.
Hi everyone, welcome to our special session on MS and sleep today. In my 20 years of being an MS nurse, I think I spent a lot of time talking about sleep and the importance of sleep and the value of sleep. And we are absolutely delighted today to be joined by Andreas, who is a neurologist and sleep physician. I think you must be the only person in the world who's combined those two, Andreas. So can you tell me why how you came to be a neurologist and a sleep physician?
Well, actually, I'm not the only person in the world, and in fact, in many places around the world, neurologists are very commonly involved in sleep medicine. But in Australia, it happens that's a bit of a rarity. So I was quite drawn to neurology as a trainee. I found it, even as a medical student, found the brain and brain anatomy fascinating, and found the disorders sort of terrifying and fascinating at the same time as well. And when I started my training and started pursuing neurology, one of the things I noticed is that I kept seeing neurology patients turning up in sleep clinics and on the sleep ward. And a lot of neurology patients telling me about sleep problems. And I thought it was quite strange that we had these patients that very often have problems with their sleep, that there's no or very little neurology input into their sleep care within Australia. So I thought about trying to find a way to do some sleep medicine and combine it with my neurology training. And just by stroke of luck, at a dinner one night, talking about epilepsy, I met a professor who said, "Oh look, I've just had funding approved to have a sleep neurology trainee at my institution over in Melbourne. So why don't you put in an application?" And it sort of all worked out very, very fortuitously for me. But I think it's a very much a needed area, and yeah, very glad to have been able to help in this way.
Very exciting. So you're working at Royal Melbourne at the Alfred now and doing some research, is that correct?
Yeah, I'm working in a lot of places. So Royal Melbourne and the Alfred are my two main sites, but I also do some regional clinics as well in Tasmania, in regional Victoria. I've been up to Alice Springs a few times. So I'm sort of all over the place a little bit. But I have been involved in some of the particularly epilepsy research and epilepsy and sleep research done at the Royal Melbourne and the Alfred. Epilepsy is sort of my main area of neurology, but being a sleep physician gives me some breadth to see patients from many areas of the specialty.
Well, thank you so much for joining us. I'm really looking forward to it, but I'm going to give it over to you to tell us a little bit about MS and sleep.
Yeah, sure. Well, thank you very much for inviting me to give this talk, and I hope it's helpful. Today, I want to talk a little bit about, firstly, what sleep is and what normal sleep is, because I find that a lot of problems with sleep stem from sort of an expectation versus a reality of what happens in sleep. I want to talk a lot about also what is a sleep physician, why would an MS patient be interested in seeing one, and sort of what to expect if you do see a sleep physician. And then I want to talk about some common sleep disorders as well. Sometimes these are pretty obvious, but people may not be aware of how to start seeking help for them. And other conditions I find tend to go unrecognized, and people may not think to ask about help for them. So to begin with, what is sleep? If we look at sort of all the different dictionaries, medical or otherwise, we find that sleep has a number of different definitions, but there are some reoccurring themes within that. So there's the idea that it's a naturally reoccurring state, that consciousness is somewhat reduced, and that it's somehow restorative, although what's being restored and how is often left out of these definitions. But we're beginning to understand a little bit more about this now, and why people sleep and what those restorative functions are. And particularly we're beginning to understand that sleep has a role in immune function, and there are major changes in the way the immune system is working when people are asleep compared to when they're awake. And I think that has a lot of ramifications for many diseases, but MS being an immunological disorder is certainly one of them. And we also know that a lot is happening in the brain during sleep. We know that there's processes of what's called synaptic pruning, or clearing of waste metabolites. So it's a sort of a tidy up of the nerves and the nerve functions in the brain during sleep. And there's also changes to memory and motor learning that happen during sleep. There's more to it than this as well. We're beginning to understand. There's some more and more papers emerging on sort of other particular brain cells that have all kinds of different functions in supporting neurons and healing and regeneration processes. We don't really understand what those changes mean in sleep yet, but it's an area where there's a lot is happening and a lot of understanding is coming out. And we know that when sleep is disturbed, we see an increase in cardiac disease, in renal diseases, in endocrine diseases, and autoimmune and neurological diseases as well. And there's sort of this bidirectional relationship of poor sleep going with chronic ill health, and which is the chicken and the egg is often the big question for researchers. So probably one of the biggest questions I get is how much sleep should I get? And the average person in their adult life is getting 7 to 8 hours of sleep a night, but there's quite a bit of variation in that, and anywhere from sort of 6 to 10 hours is pretty common. Even outside of that is not that rare, and all of this can be normal, which is something that I think a lot of people don't recognize. We tend to get more sleep in our teenage years and early 20s, and then in later years, our need for sleep tends to decline. So there's a lot of variation over the course of normal lifetime and within the normal population. We divide sleep up into different stages. So we talk about wakefulness, we talk about N1 sleep, which is the drowsiness, should constitute a fairly small portion of sleep time. N2 sleep, which tends to be a lighter sleep. N3 sleep, which is your deep sleep or your dreaming sleep, and your REM sleep, which is about 20% of your sleep time as well. REM sleep is rapid eye movement sleep. It's typically when dreams are occurring. One thing that's important to recognize is a lot of people get concerned about not having enough slow wave sleep or not having enough REM sleep, and they don't actually realize that the proportion of time that you're having N3 sleep or slow wave sleep or your dreaming sleep for is actually a fairly small portion of sleep overall. And so I've blown up this graph a little bit. This is a normal sleep cycle. This would occur over 60 to 120 minutes typically. You start out with a little bit of drowsiness, you go into a lighter sleep, then into a deeper sleep, and then at the end you transition into your dreaming sleep, and then this cycle repeats throughout the night. That's normal, but not every sleep cycle is created equal, and so this is a number of sleep cycles grouped together, and what you can see is that early on in sleep this person is getting quite a lot of slow wave sleep but very little dreaming sleep, and as the night progresses they're getting less slow wave sleep and more REM sleep, and this is normal. This is what happens to everybody through the night. Your dreaming sleep tends to, your slow wave sleep tends to predominate early in the night, and your dreaming sleep becomes more in the early hours of the morning. And it has some ramifications, because if we look at this slide here, you can sort of see in the first half of the night the person's in very deep stages of sleep, and in the latter half of the night it's mostly in dreaming or in very light sleep or drowsiness even. So people often come to sleep clinics saying, I get 3 or 4 hours sleep early on in the night, and then I don't sleep for the remainder of the night. I lie there awake for 3 or 4 hours. Often when we do the sleep study, we see that their sleep looks more like this, and actually they are sleeping in those early hours of the morning. It's just a much lighter sleep with more transitional stages and more dreaming stages. And it's very easy. I think a lot of people dream about lying in bed awake because you can clearly record that they are actually sleeping during this time, but it may not be the same sort of sleep that they're having earlier in the night. It's important, I think, to recognize that that's normal and that's not necessarily a major problem, and it takes a bit of the anxiety and worry about sleep for a lot of people to realize that. So how do we sleep? We humans have this sort of very strong, we call it a bistable flip-flop circuit. It's a term borrowed from electrical engineering, where you're either awake or asleep, and you don't really switch between the two of them very easily. You should either be awake or asleep. And in fact, we know that the neural circuits that control wakefulness are able to promote themselves. So wakefulness promotes wakefulness, and sleep promotes more sleep. And also sleep inhibits wakefulness, and wakefulness inhibits sleep in normal neuronal function. And it takes quite a bit of pressure for a switch in the circuit to occur. And that's this big blue bolt of lightning here is comprised of psychosocial factors, of homeostatic factors, and circadian factors to push people from being awake to asleep, or from being asleep to awake again. So when we talk about homeostatic factors, we're talking about a sort of gradual build-up of tiredness and fatigue through the day, which is represented by the red line, the S here, in this diagram. And in this case, you can see that over the sort of 7 to 11 o'clock, that this person is doing stuff and building fatigue until they sort of get to a point where they go to sleep and it all gets relieved again. And this is working in sync with this person's circadian rhythm, which is climbing during the day and falling during the night. So these are the two factors that need to work together in order for sleep to occur, or should work together in order for sleep to occur. When we're talking about circadian factors, this is possibly a little bit of a complex slide, but we talk about a specific nucleus in the brain as being the brain's natural clock. And that's the suprachiasmatic nucleus. This nucleus actually does have a pacemaker function, which essentially records time, and is around 24 hours in its cycle. And it gets entrained to normal daily cycles by the presence of light. So light and the suprachiasmatic nucleus control the release or suppression of melatonin that your body produces. And this helps to get your body into a normal circadian rhythm, gets you into a good sleep-wake cycle. So sleep disorders, coming to MS now. I think anybody that's worked with MS patients knows that sleep disorders and fatigue is extremely common in these patients, and that's borne out in every study that I've ever managed to read on the topic, that sleep problems are very, very common. Sometimes 60 or even 70% of patients will have problems with sleep at some point in the course of their illness. And there's many things that occur. Sleep apnea is thought to be more common. Insomnia is common. Restless leg syndrome can occur. A narcolepsy or narcolepsy-like syndrome can occur. And probably the biggest one, though, is just fatigue and being tired a lot of the time. And the question that comes up is this multiple sclerosis causing a sleep disorder, or sleep disorders causing MS? And what role do they have in relation to each other? I think there's two things in this process to think about. The first is, with any chronic illness, we know that sleep disturbance becomes more common. whether that's because people are worried about it, whether there's anxiety related to the diagnosis or the treatment, the effective medications, all of these things and more probably play a part. So sleep disorders can certainly arise alongside multiple sclerosis, but I think that a lot of the factors that we've talked about in terms of circadian rhythm already relate to the function of brain activity. Wakefulness and sleep result from brain activity, and so we also know that there can be injury to the brain that can result in sleep problems in various disorders, but I'm certain that it would be similar in MS. So it creates a bit of a problem of is the sleep disorder just happening alongside this, or is it actually part of the disease process? I don't think it's either or, I think it's both and. So some of these will just occur alongside and some will occur as part of the disease process. And it's important, I think, to try treating these things, because more often, I think, they are not related to the disease process and occurring incidentally, and can respond very well to treatment. The other question I sometimes get asked is, does my poor sleep contribute to multiple sclerosis in any way? The short answer to that is we really don't know. I don't think that there's a body of literature yet that confirms that this is the case, but it's certainly a topic of interest, and there are associations, as I said, between poor sleep and changes in immune function and so on. So it may become an area of interest in the future. But one thing that I really wish to highlight is that probably one of the major issues that we see around poor quality sleep is people who are worried about poor quality sleep, and the sort of self-fulfilling prophecy that emerges from that. So although this is an area of interest, I think it's also something to just take a step back from on as much as possible, and not dwell on or worry about too much, because it's ultimately not going to be as helpful for your own sleep. So when to see a sleep physician? My opinion is that people should see sleep physicians sooner rather than later. I think there's a lot that sleep physicians have to offer. Anyone who's feeling sleepy or tired, and the sooner we get onto that, the sooner we can be productive and do something useful in terms of helping. So sleep physicians, we're doctors, we're specialists in medicine, a bit like your neurologist is a specialist in medicine. When you see a sleep physician, they're probably going to want to sit down and talk through a history of your sleep problems. And for example, I'd often ask people about what time they get out of bed in the morning, what time they wake up, and then what time they actually get out of bed, and what's sort of getting them out of bed. Are they sort of been woken up by screaming kids or the angry cat, or by their alarm system, or are they waking up naturally at that time? And it sort of gives some hints about whether that person has a really strong circadian rhythm or not. And we then tend to ask about daytime function. Does your sleepiness impact you at all? And oftentimes people say that they're a little bit sleepy, but then the sleepiness doesn't ever seem to really impact their day-to-day function. They're doing fine, and it becomes a bit of a question of, okay, well, is the sleep really a problem then? Because sometimes the cure is worse than the issue. And then we always ask about sleep as well. So what time are you heading to bed? How long is it taking you to fall asleep? Do you stay asleep or do you wake up frequently? And also, what is the quality of the sleep like? There's often a brief physical examination involved. It's much less than you'd be used to with any sort of neurological examination. The first couple times I examined sleep patients for sleep problems, I was convinced I must have forgotten something in the examination and went back and did it all over again, because I couldn't believe the examination was so short compared to examining patients for neurological diseases. But it's still important and useful. And then very often a sleep physician will order a sleep study to try and investigate further into the sleep disorder. So the polysomnogram or sleep test is the sort of gold standard test, but there are different sorts of polysomnograms. So there are some that are done in the lab, and there are some that are done home-based, and these can both be very good ways of assessing sleep. The studies will assess brainwave activity. They will assess airflow, usually through some sort of nasal cannula. So this is a little pressure sensor that sits around the nose, as well as the respiratory bands. So these go around the chest to measure the chest wall activity as you're breathing in and out. Oximetry is a tool used to measure the oxygen saturation in the blood. You may have had this before or seen it, the little clip that sits on the finger. And then there's measurements of heart rate and muscle activity also. So it can be very involved, and there seems to be lots of dots and wires to contend with when you have a sleep study. But it gives a lot of useful information to the physician about what's happening in your sleep, where are the problems, and what can be done about them. I would just point out that in general practice, the two most common causes of sleep that we see are probably unrecognized mood disorders, so depression, anxiety, or things like this. And the other one is an insufficient sleep syndrome. So this is people that, for whatever reason, are not really giving themselves enough time in bed. And I sometimes, well, I fairly often see people that come in and say, I'm getting 8 hours sleep a night. I don't know why I'm so tired. And I say, well, what time do you go to bed? And they say, well, go to bed somewhere between sort of 1 and 2 o'clock in the morning. So what time do you get up for work? And they say 7 o'clock. And I go, that's not 8 hours of sleep. That's 5 or 6 hours sleep. And it seems to come as a bit of a shock. I don't know why, but people often seem to underestimate the impact their sleeping hours are actually having on the total amount of sleep that they're getting. So it seems to be common that people underestimate or perhaps overestimate how much sleep they're getting, and that can be a real cause for sleepiness. So I want to spend the next part of the talk just talking about some common sleep disorders and some of the ways that physicians will investigate this, and some of the things that you can even pursue yourself to look into these a little bit further and try and make a start with. Probably the most common problem that we see all around is insomnia. So insomnia is when you're not getting good enough sleep duration despite the opportunity. So people are going to bed, but for whatever reason, they're not able to get to sleep, or they're waking up frequently, or they're waking up early in the morning. We tend to describe this now as acute or chronic. So acute insomnia is an almost universal human experience. You know, you have an exam, you have an important appointment, you have some sort of stress with finances, with ill health, with any of these sorts of things, and naturally you can't sleep at night. You lie awake thinking about things. But that tends to resolve as those issues go away. And chronic insomnia is when it doesn't resolve, and you're left with insomnia symptoms that persist for a long time after the initial problem has gone away. And we used to use the terms primary and secondary insomnia, so primary being insomnia that occurred by itself, and secondary referring to insomnia that was caused by another disease or illness. And these terms are used much less these days and sort of fallen out of favour, as we tend to treat insomnia the same, regardless of whether it's primary or secondary. So this is a very famous model of insomnia. It's very commonly used, and it's one that I go through very often. And if you think back to my earlier slide talking about 3 factors that drive sleep, so there's the psychosocial aspect, there's the homeostatic factors, and there's the circadian factors. This 3Ps model really deals with the psychosocial factors. And in this model, you have a person that might be perhaps prone to insomnia and difficulty sleeping. There's a number of factors that can be involved in that, including genetic factors, as well as just traits in people's behavior. People that tend to be a bit more anxious or worried may have an inclination towards insomnia. And then you get some sort of precipitating event that drives bad sleep, and that's represented by the orange here. And this can be getting an illness in the family, stresses or worries, traumatic events, anything like this. And that naturally disturbs your sleep, happens to all of us at some point in our lives. And then slowly this begins to resolve and eventually goes away. But it gets replaced by a number of perpetuating factors in chronic insomnia. And these are principally related to sort of symptoms of frustration. So I can't get to sleep. I'm not doing so well because I'm angry because I'm not getting sleep. I'm not doing as well at work because I'm not getting to sleep. I'm frustrated by my inability to sleep. And that can then become part of the problem about sleeping. You also get this sort of phenomena of sleep anxiety, where people are becoming excessively worried about their sleep, and the worrying about sleep is what actually ends up disturbing the sleep. And if you can help really reduce that anxiety, you can often help the sleeplessness. And then you can get compensatory sort of factors as well, which can be perpetuating, such as napping during the day or doing other activities during the bed to try and relieve the frustration, but then that tends to perpetuate other problems. So these are important things that will probably come out in the sleep history as well, but are useful targets for sleep therapy. And then we look at the sort of homeostatic and circadian factors as well. And this is the same graph I showed you before. So the red line there is person getting more tired over the day, and the green is the circadian factors. And I've replicated that here. So this is a normal person sleeping well. And you can see that this orange line is their homeostatic drive. They're building up their fatigue over the day. They hit this threshold at the same time their circadian rhythm is declining, and they're able to get to sleep and sort of restore their homeostatic drive. What happens in insomnia tends to be more like this. So we see this person has decided to have a nap around 1 or 2 o'clock in the first day. And so instead of their homeostatic drive building up through the day, it actually gets restored a little bit during the day. And then when it starts to build up again, it doesn't build up all the way to that level where they need to sleep. And so when they go to bed at night, instead of getting restored properly, it gets restored much slower. And consequently, when they wake up, they're not actually fully refreshed. They're still tired. And so they're doing less during the day, and they have another nap during the afternoon. But the nap doesn't completely refresh them either. And this sort of goes on and on and on, and sort of show patients this and say, it's like being stuck in limbo. You know, you're never getting to fully tired, and you're never getting to fully rested. You're just sort of stuck in the middle, going up and down. And that makes sense to a lot of people. And so factors in insomnia, there are many different ways we can treat insomnia, and we often use multiple different approaches. When it comes to the psychosocial factors, just dealing with the sleep frustration and anxiety can be really powerful and important. And this is often something that we would do by referring patients to a sleep psychologist, and also just through a process of education for the patient. And a typical one would be someone that comes in saying, I've got this Fitbit, and the Fitbit tells me that I'm sleeping badly, and now when I go to bed, I'm worried that I'm not sleeping well, and so I can't get to sleep. And 2 years ago, before I got the Fitbit, I was fine, but now I'm lying in bed awake all night worrying about the poor quality of my sleep. And that's actually a fairly common thing to get. There's a whole phenomena of sleep insomnia and sleep problems related to using Fitbits and other sort of devices. It's not just Fitbits. I shouldn't be unfair. But people can start to worry about their sleep, and so rather than being a tool for help, it becomes a hindrance to them. And this can then be tackled by sort of talking through, well, you managed to survive the last day without getting the sleep that you wanted, and by reducing some of the anxiety around sleep and working out why people are worried or anxious about sleep. Something that's really useful for this is to do a bit of a sleep reset. So something that I often teach my patients to do is, if you get into bed and you're lying there worried about the quality of your sleep, wondering if you'll get to sleep and what your sleep will be like, and that starts to wake you up and get you sort of feeling agitated and alert, it's good to get out of the bedroom and go and do something else for a while, put those thoughts down on a paper, do some colouring, do something completely different. And then when you start feeling tired again, come back to bed, hopefully without that frustration and anxiety, and try and get to sleep like that. And this takes a while. It takes a while for that practice to start to work, but when it does, it can be very powerful in relieving that anxiety and frustration. And of course, a sleep psychologist will have even more ways of trying to deal with that and to help reduce that burden. Conditioned arousal is another common outcome from this behavioural model, and what this refers to is the process by which going to bed becomes a wake-promoting activity, essentially. And so the typical story here is someone that says, you know, I'm tired through the day, I sit down on the couch at the end of the day, I can't get through a TV show because I'm falling asleep during the TV show. I go to bed and I'm more awake in bed than I am at any other point during the day, and it's maddening. And this person has a conditioned response. They've learned somehow that going to bed means waking up and being annoyed about that. And this is something where I think seeing a sleep psychologist can be really useful, because it's hard to break that mental association by yourself. It's very, very challenging. It can be done, and in fact, sleep psychologists have a fantastic success rate, over 90%, in terms of helping people break these associations and get to sleep. But it does take work and effort from the patient to do. People often ask, isn't there a medication I can take to do this? You can try, but unfortunately the efficacy of medications is somewhat limited in this area. What you'll find is that if there's a strong enough conditioned arousal, the brain can start to overrule or override the homeostatic and circadian factors and even the medications. So it's not uncommon for me to see patients in clinic that say, I've tried 3 or 4 different hypnotic medications and none of them work. And the reality is that unless you deal with some of the psychosocial drivers of this poor sleep, that the medications don't really have a chance to help out in the way that they should. When it comes to homeostatic factors, inactivity, immobility during the day can be a really big problem, particularly for people with disability, where it's difficult to become active and to do things. And similar with circadian factors, you know, morning sunlight is something that we talk about all the time, and regular wake-up times extremely important in setting that circadian rhythm. But if you're stuck in bed because of disability or pain issues or other things, it's very hard to get up and go and see the sun. It's very hard to be active during the day. And this then creates another psychosocial problem as well, where, you know, the bed is a place where you are in pain, you're awake, you're thinking about things, you're doing your work, you're doing your shopping, you're doing all other sorts of activities other than sleeping. And it's like taking all of that stress and anxiety and problems to sleep with you, and of course that's not going to work for people. So how can we help with this as sleep physicians? Well, we try and work out which is the main factor. Is it a psychosocial behavioral thing? Is it a homeostatic thing? Is it a circadian thing? And how can we start to address each of these? And there are ways, even with immobility and inactivity, that you can make some positive changes. So I know patients that have learned that sitting up in bed is a time to be awake and thinking about things. Lying down is a time to be asleep. And it's very difficult to sort of make that distinction, but it can be done, and it can be really, really powerful when people do go, okay, this is how I'm doing this and this is how I'm doing that. Other people will say, well, I'm going to go to a chair at least in my bedroom if I can't get out and be more mobile. And so I spend the day in the chair and the night in bed. And I'm going to have, this is the being awake place, and this is the being asleep place. One of my sleep psychologist colleagues recently told me that they had a patient who really couldn't even sit up properly. And so they did a lot of work around just trying to learn that, they had one doona for sleeping and a different doona for being awake, and that was the difference. And they sort of had this dull, dark one for sleeping and this bright, colourful one for being awake. And so when they couldn't leave their bed, they could at least make these changes in their environment that were strong enough to sort of get some associations developing with what they were supposed to do. And there are also devices that you can use. So people use blue lights as sort of wake promoting lights. There's a retimer devices, which is like a set of glasses that can help give you blue light directly to the eyes, and it's supposed to help set that circadian rhythm in the morning and promote wakefulness. So lots and lots of different methods to be able to help with this. And a good resource for this is actually the Sleep Health Foundation, who I've put up here. So I'm not affiliated with them. I don't get paid by them or anything like that. But they provide a lot of really good fact sheets and information sheets. And in fact, their website's recently been updated with more information, and they provide a lot of information, a lot of good information for my patients around insomnia and sleep management in general. So well worth having a look at if you're able to do so. A really commonly related problem to insomnia is what's called delayed sleep phase disorder. And this is basically a problem where the body clock and the social clock are not aligned. So instead of sleeping from 10 p.m. till 6 a.m., a person's natural inclination is to sleep from, say, 2 a.m. till 10 a.m. And this can cause problems in their working life and working environment, as they are tending to be late in the mornings, and it can cause a lot of other social issues. Often when people are working, the big problem is that on the weekend they stick to their natural rhythm of 2 till 10, and then during the working week they have to get up at 7, so they're getting really reduced sleep hours during the week, and then only getting to normal sleep hours on the weekend, which doesn't tend to work well long term. It's also often a problem in people who are off of work, where they lose the schedule that work provides. So it's not uncommon for me to see this in people that have recently retired, or people that have lost their job, primarily because they no longer have a reason to get out of bed in the morning. They're not pushed to get up, and this then means that their sort of sleep-wake cycle comes out of whack. They tend to sleep in, but then they can't go to bed on time, so they go to bed later, so they wake up later, and they can end up sleeping at very odd hours of the day, and that can be really problematic for them. They can feel very, very upset about it. The first question I always ask them is it really a problem for you? If you have to get to work, yes, it's a problem for you, I understand, but a lot of the time it's just become a new normal for them. I go to bed at 3, I get up at 11, that's what I do, and it's as long as I stick to those hours, I'm okay. And if you don't have anything on, and you don't need to be up at any particular time, I don't think that there's a real major problem with doing that. It's only when it starts to impair social functions that it becomes problematic. So that's the first thing. And then the second step to it, well, if it is a problem, how do we treat this? Usually the best way I've found to treat this is when a person comes to me with this sort of issue, I'll say, look, I want you to be in a really regular rhythm. So I want you to be getting up at the exact same time every day without fail for a month, not 15 minutes later, not half an hour later, the exact same time. I don't care when that is. I don't care if you're getting up at midday, but I want you getting up at a consistent time. And then I want you to slowly start bringing that back, even by like 5 or 10 minutes each day, until you get where you want to be. And that can be a time-consuming process, but it ends up being a very effective process as well. So I wanted to speak about obstructive sleep apnea now, because this is one that's very common and sleep physicians are very, very interested in. So obstructive sleep apnea syndrome, it's a disorder where you get obstruction of breathing during the night. So in all of us, when we sleep, all the muscles in the body relax. That includes the muscles in the upper part of the airway, and the throat will start to close up and narrow down. When it gets narrow, that's what causes snoring, and snoring is something that almost every person will do at least a little bit of in their lifetime. And when the body relaxes a little bit too much during sleep, you do get a collapse of the airway and a brief pause in your breathing. And this is actually normal. It happens to most people once or twice a night, and that's completely fine. When it starts to change, when it starts to go from once or twice a night to 40 or 50 times an hour, that's when it's changed from being a normal thing to being an abnormal thing, and gone from being normal respiration to being obstructive sleep apnea. So it's a question of how much, and then what impact does that have. So the most common associations of obstructive sleep apnea are that you have poorer quality sleep, you feel fatigued and sleepy through the day, and it has strong association with worse mental health. There are a range of other issues that obstructive sleep apnea has been linked with. So cardiovascular disease is very, very well known association of obstructive sleep apnea. There have been links to dementia and other neurodegenerative processes, links to endocrine problems, and so on and so forth. These are still not fully understood scientifically, and whether these are just happenstance associations, whether there's a causal relationship or not is not as clear. But it's still an area of a lot of interest. And some of the associations, for example, with cardiovascular disease are pretty strong. So how do we treat it? Probably the most common thing that people hear about is continuous positive airway pressure therapy. So if you do have significant sleep apnea and that airway is collapsing, this is a machine with a mask. This particular example I just took from the ResMed website. Not affiliated with ResMed at all. It's just the first one that came up when I was looking for something to show you. These masks can be quite big, so you can get some that go the whole way around the face. You can get some that just go around the mouth and nose. You can get some that just go around the nose, or even just under the nose even. And all of these can be a very effective way of pushing some air back into the airway, opening up the airway and allowing people to breathe normally again. And when people do have severe sleep apnea, you can see a major difference in their lives when they start using CPAP. I've seen people that were about to lose their job and their marriage is breaking down, and they're just falling asleep on everyone and everything all the time, and it's causing huge problems for them. And they start on CPAP, and it's an absolute game changer. They come back feeling like a completely different person, and it's extremely heartwarming to see those really good responses to treatment. There are other people though where sleep apnea might be much more mild, or the CPAP might not be tolerated at all, and that does happen, and it's not anyone's fault that that's the case, but there are other options as well. So sometimes weight loss can make a great deal of difference. Sometimes positional therapy makes a huge amount of difference as well. Someone might have sleep apnea when they're lying on their back, but not when they're on their side, or when we're sleeping with the head of bed elevated. So this can be useful in some cases. There are mouth guards that can pull the jaw forward as well, and these can be very useful for sleep apnea. And sometimes we even talk about surgery for sleep apnea if it's a serious problem as well, and no other treatments are being helpful. Restless leg syndrome I wanted to mention because I find that it's a condition that's often not really asked about, and patients don't really know that it's a condition, and so they don't mention it. But when you do talk about it, it's quite obvious that that's what the major issue is, and it can be very easily treated. So it's an often under-recognised condition in my experience. What is it? It's this sort of uncomfortable, weird sensation. People find it very difficult to describe exactly what it is. Sometimes it's an itch, sometimes it's a very deep, unpleasant feeling in the legs, and it's associated, it's typically in the legs, I should say, sometimes in the arms as well, or in the rest of the body. It comes on in the evening as you're trying to get to sleep, and it comes with this very strong sense that you need to move or get up or walk around. And people often say, if I get up and move, the symptoms diminish almost completely. Sometimes they go away completely as well. But then as soon as I lie down again, they start up again and are causing me to not able to get to sleep. So as I say, it definitely occurs, and I think it's under-recognised in the general population. There are some very simple things that can help. Just doing leg exercise, calf raises, or doing some brisk walking, or some pedaling on a stationary bike or something like that, just before you're going to sleep, often prevents the onset of symptoms long enough that people can get to sleep and then they're not bothered by it. It can also be related to iron deficiency. It can be related to some medications as well. And then there are also some medications that your doctor could prescribe that can be very effective in managing this. So it's not something that people need to suffer with. And generally you can get really, really good control of restless leg syndrome, generally. And then the final one that I wanted to talk about was narcolepsy. So narcolepsy, there's two types of narcolepsy, type 1 and type 2, and it's a disorder of excessive daytime sleepiness. So people will have a tendency to fall asleep really quickly and really suddenly, and they often feel like they get this wave of sleepiness just hits them, and they can't stop themselves. They have to get to bed and to sleep, or they might just fall asleep at their desk or wherever they're going. It can be associated with cataplexy, which is a sort of sudden loss of muscle tone where people will collapse to the ground, with hallucinations as you're falling or waking up from sleep. It can be visual or auditory, and also sleep paralysis, where people wake up from sleep but not be able to move their body, and that can be very, very frightening. And sometimes it's caused by, or sometimes it's associated with disrupted sleep as well. And type 2 narcolepsy is a little bit harder to define. There is the same excessive daytime sleepiness that you see with narcolepsy, but the other symptoms are much more variably present, and cataplexy is not present. And so how might your sleep specialist help or work this out? Well, often you see the sleep specialist, you've done a sleep study which has excluded other disorders, and then there's a test called a multiple sleep latency test. Sometimes people do maintenance of wakefulness tests as well. And this is essentially where, with all the sleep monitoring equipment on, we put you in a dark room and say, we want you to try and fall asleep as quickly as possible. And we see if you get to sleep within a short period of time, or whether it's a longer period of time. And we're looking to see if people do fall asleep very, very quickly, consistently through the day. Narcolepsy occurs in the general population. It does occur in MS patients as well, so I think it is worth thinking about. But at least my experience has been that the MS patients unfortunately seem to respond a little bit less well to medications than other patients. That being said, they do have some response. So again, it's worth seeing a sleep specialist and looking for this, and at least trying to do what we can to help. And if nothing else, it's a diagnosis. We can help then with some lifestyle factors and other things to help support people with this. So in conclusion, I would really like people to take away that there's a lot of variation in normal sleep, and there can be many different phases to sleep as well, where people are sleeping more in deep sleep, more in REM sleep, and more in lighter sleep. And just because you have a difference to normal doesn't necessarily mean that there's a major problem. But also to know that sleep disorders are common in MS and in the population in general, and that these are amenable to treatment. There are some really good treatment modalities available, and often these can have a really major and positive benefit to patients in their lives. So I hope that was helpful.
That was great, thank you. I learned a lot about sleep. I learned a lot about sleep. I did have a couple of questions that I was writing down as I go along. So thank you so much for that. That was fantastic. One of the things that I was thinking about, often in like most conditions, we talk about the value of early intervention. Like just sort of that question, I guess, that was so common was when actually is the time to see a sleep physician? You know, when do you know that that this has become a real problem, and also then is early intervention a thing, I guess, in sleep as well?
Yeah, so I think in general, something that we don't really do well enough in medicine is prevention, and good healthy habits in terms of diet, activity, and in sort of having good sleep routines and good sleep hygiene to prevent problems is something that we're not good at helping people with, and not good enough at promoting in general. So I think that you know, you can start preparing for sleep disorders from a very early time in your life, and that can be very beneficial. But when should patients see a sleep physician? I think for me, as I've said before, I'd say sooner rather than later. So if you're noticing that sleep is a problem for you at any point in your illness, it could be worth seeing a sleep physician. Don't leave it until the point where you've got a really deeply entrained habit of poor sleep, or that you're falling asleep at your desk and getting into trouble at work. That's really not necessary. Of course, if you're in that situation, we can still help. It's not like you're beyond anything, but you don't need to suffer for that long with poor sleep. You can come and see someone, and we should be able to help you make significant improvements even early on in the process.
Mm.
And oftentimes, I've seen people that have been worried about their sleep early on, and you do the sleep studies and the other investigations and everything's fine and normal, and that can be such a weight off people's mind as well. So even if you don't find a disorder, just knowing that things have been evaluated thoroughly, and that there aren't problems there that you need to be concerned about can be really important for people as well.
Yeah. Naps was my next thing. Naps, and a lot of people with MS ask me that question: should I have a nap? Should I push through? With fatigue being such a problem, what's your general? I mean, it's probably specific to people, but do you have any sort of general advice about that one?
Yeah, I do. So one of the things that I often talk to patients about in this situation is, if you have a nap, what happens to your nighttime sleep? So if someone's getting a good 8 or 9 hours of solid sleep at night, and then they have a nap halfway through the day, and it's really helping them function better through the day, but they still get their 8 or 9 hours sleep at night, I don't have a problem with that. And in fact, with other disorders of hypersomnolence, we often use naps as a therapy. So I have a lot of patients, well, I have a few patients with narcolepsy that don't like medications for whatever reason. They cause side effects or other problems for them. And having a scheduled nap of an hour each day helps to treat their sleepiness really effectively and really well. And it doesn't stop them from sleeping well at night. But if someone's coming in and saying, should I push through or should I have a nap? And I say, what happens if you have a nap? They say, oh, well, then I definitely won't get to sleep until really late tonight, and my sleep will be really disturbed. That's a person where I really want to be a bit more cautious about having naps regularly, because I suspect that they're sort of getting some refreshment during the day, which is then stopping them from sleeping well at night, which is then meaning that they're not refreshed the next day, and they get stuck in that sort of limbo phase. But it's not a one size fits all. there is variation in there as to what's working for each individual.
My other question was around symptoms waking you up, and it's a bit of a chicken and egg sort of thing, but a lot of people say that it's either their MS symptoms waking up, and as MS is, you know, in women, it's the menopause things waking them up, so something's waking them up at night. What's your thoughts around, is it chicken and egg, or managing that?
It's an interesting one. We know that menopausal symptoms can be very troubling for women, and that's a time where sleep quality tends to decrease in all women, unfortunately, and so that is a real and genuine thing, and there are treatments for menopausal symptoms that your general practitioner will be familiar with, that can be really useful for that. When it comes to MS symptoms, I don't have any study evidence around MS specifically, but I can draw an analogy to another area, which is waking up to go to the toilet at night. So this is a very common problem for people as they get older, particularly men as they get older with prostate problems. And we see a lot of people that come in and their main problem is not their snoring or their sleep apnea, it's that they're getting up 4 or 5 times a night for the toilet. But when we do a sleep study, we find that they actually have bad sleep apnea. And a colleague of mine did a study recently that showed that when you treat their sleep apnea, the number of times that they need to wake up to go to the toilet actually decreases quite significantly. And we know with sleep apnea, when your breathing is stopped and your oxygen levels are dropping, you get a bit of an adrenaline kick, and that's what's thought to drive the high blood pressure and other problems in sleep apnea. But of course, adrenaline also stimulates your bladder. So our suspicion, sort of looking at the data, was, well, maybe the sort of the problem with the apnea is driving some adrenaline-related changes, which is making patients wake up more to go to the toilet. This is sort of the hypothesis that we put, or that he put out, which I think makes sense intuitively. So I think what I'm getting at is sometimes there's more than one problem going on, and it can be that you have sleep apnea, which is very treatable, which is triggering some other problem or reducing your degree or depth of sleep enough that your other problems are waking you up. So although it's very valid that the symptoms, particularly pain symptoms, are often difficult and can wake patients during the night, that can be very challenging for a sleep physician. It can also be that simple disorders are driving waking at night, and by treating those with very effective, well-established treatments, we can improve quality of sleep dramatically for people as well. So that's my general advice when I see people with MS, has been let's find out what's treatable and what we can reverse here and what we can manage better.
Yeah. Well, that kind of is about my last question that I had. Well, I had more, but I'll stop there. That sleep apnea, it was a bit of, you know, I remember in clinic it was often not till it was really obvious that someone was snoring that we would sort of send them to sleep apnea. Do you think it's under-recognised, and is there something that you would say, hey, we should, you know, is it underdiagnosed was the word I was looking for, and is it something we should be more aware of as for people living with MS and as clinicians?
Yeah, I think you know, sleep apnea is sort of a relatively new diagnosis still in terms of medicine. People have been a bit more unaware of it until recently, and now it seems that the more we look for sleep apnea, the more we find it. So you know, every now and then there's a study that comes out that says, you know, it used to be thought that it was 5 or 10% of people have sleep apnea. Now it's gone up to 15. There are some studies that show that, you know, 70% of people have some sleep apnea in their life. So it's probably a more common thing than we realize. And I think that it's worth asking about and looking for semi-regularly. So with my epilepsy patients, I tend to ask about symptoms like that. I try and remember to do it every couple of years, to just ask again about those symptoms and see what's changed. in a similar way that you ask about other sort of general health considerations. And I think that, yeah, it's probably because fatigue is so common in MS patients. I think that looking for those reversible causes, the things that we can do to help patients is really important. So I'm not sure how often it gets done, but I think I would encourage people to think about it as an option earlier rather than later.
Mm-hmm. Well, thank you for your time. Thank you for all that knowledge.
Jodi, we did just have one question that came through.
Yeah.
Just around whether a sleep physician can also help with nocturia as part of the problem with not getting sufficient sleep, which I think Andreas did sort of briefly touch on.
Yeah, I think that that in my experience, that generally the sleep physicians know, because it was a bladder dysfunction and related to that. I mean, it's complex, of course, the combination of the two, I think, which Andreas did touch on. But generally, we tried to treat the nocturia as a bladder dysfunction related to MS, as opposed to, which is nocturia is having to get up at night to go to the toilet a lot, or even just more. Yeah, so that's tried to treat the nocturia as a MS, a bladder dysfunction.
Great, and that was sort of all the questions that we had sent through.
Okay, well, thank you everybody for. I hope that you learnt something from that from that presentation. And again, if you have any questions, always please get in touch with us. Particularly with sleep, there's always a lot of one-to-one questions about medications particularly, and are they impacting on your sleep? So if you have any questions, then please let us know.
Great, thank you for that, Jodi. Here are some of the other supports and services that are available through MS Plus, including our Plus Advisor service. So we have MS nurses that can speak with you about sleep issues or anything else that you might have questions around, and you can access all of this through Plus Connect. You can find more information on our resource hub. So this is where we have all of our webinars, podcasts, articles, and the In Touch newsletter. If you'd like any more information or you have any questions after today's webinar, you can get in touch with Plus Connect on 1800 042 138 or via that email address, and the team will be able to assist you.
Thanks, Jess, and thanks everyone. Have a great day.